Welcome to the deep dive. Today we're getting into something that affects, well, a huge number of people. Atopic eczema.
That's right, also known as atopic dermatitis. We've got some pretty comprehensive revision notes, clinical overviews here, focusing just on this condition.
And our plan really is to unpack these together. Pull out the essentials, make it really clear and high yield, especially if you're using this kind of material for revision yourself.
Definitely. And it's so relevant, isn't it? I mean, it's incredibly common, especially in kids. And as these notes show, understanding it goes way beyond just skin deep.
It really does. Okay, let's dive in. Starting right at the beginning, what is atopic eczema, according to these notes?
Well, fundamentally, the material defines it as a chronic inflammatory skin condition. So the keywords there are chronic and inflammatory.
And the main features?
It's characterized by itchy, dry, and inflamed skin. That itch. That's really the hallmark.
And the notes are quite clear on its impact, right?
Yeah.
Saying it's the most common inflammatory skin disease here in the UK.
Yeah, that statistic is striking. The prevalence is just massive.
Most common. Wow. And onset, typically childhood.
Usually,
Yeah.
yeah. It often starts in childhood, and this is important, it can absolutely persist into adulthood, or sometimes even appear for the first time then.
Right, so not something you necessarily just grow out of.
Not always, no.
Yeah.
The initial overview, it sort of lays out the basics of management straight away. The cornerstones.
Tar.
General skincare measures, using plenty of emollients, moisturizers, avoiding triggers, and then topical steroids for the flare-ups. Those are kind of the four pillars.
Got it. Emollients, triggers, steroids for flares, general care. And the notes add some other key points.
Yeah, they mention, again, it hits all age groups, but it's definitely more common in the under fives. And typically, the rash pops up in skin creases, behind the knees, inside the elbows.
Yes, the flessural pattern. That's a classic sign, isn't it?
It is, especially in older children and adults. And this is crucial. The notes link it strongly with other atopic conditions, things like asthma, hay fever, allergic rhinitis.
The atopic march. They often come as a package deal.
Exactly. It suggests this underlying tendency towards allergic-type reactions. It's not just isolated to the skin.
Okay, that makes sense. So why does it happen? What did the notes say about the etiology, the causes?
Well, the material really emphasizes that it's complex, not just one single thing. It's a combination, an interplay between your genes and the environment.
So, you might be predisposed, and then something sets it off.
Precisely. The notes break it down into sort of three interacting components. An immune system that's a bit dysfunctional, kind of overreacting.
Okay.
An impaired skin barrier, so the skin itself isn't protecting as well as it should.
Right, like a leaky wall.
Kind of, yeah. And then environmental triggers that basically exploit those weaknesses. It's this cycle between the immune system, the barrier, and the triggers that keeps it going.
That interplay seems key. Barrier lets things in, immune system overreacts.
Right. Now, the notes distinguish between risk factors and trigger factors. How should we think about that difference? Good for revision, maybe. Yeah, that's a really useful distinction. Think of risk factors as things that make someone more likely to get eczema in the first place.
Okay, increases the odds.
Exactly. Whereas trigger factors are the things that make existing eczema flare up or get worse day to day.
Got it. So what are the big risk factors mentioned?
Family history is a major one. If your parents or siblings have eczema, asthma, or hay fever, your risk is higher.
Makes sense, the genetic link.
Yeah. Also, exposure to irritants, dry climates, secondhand smoke exposure in childhood is mentioned, and interestingly, high birth weight.
High birth weight. Really? That's unexpected.
It is a bit, but it's in the notes. Also, living in polluted areas or places with extreme weather conditions.
Okay. And triggers. What sets off a flare? The list seems quite long in the notes.
It is. Environmental stuff is big. Soaps, detergents, perfumes, common irritants, also specific allergens. Skin infections are really key triggers, especially Staphylococcus aureus. That bacteria loves eczematous skin and makes it worse.
Right. Staph aureus. We'll probably come back to that. What else?
Extremes of temperature or humidity, very hot, very cold, very dry air. Rough fabrics like wool.
The itchy wool jumper. Classic.
Decidedly. Dietary factors can play a role, especially in kids, but that usually needs proper investigation. Inhaled allergens too, pollen, dust mites.
Okay.
The notes also call out specific genetic mutations affecting a protein called filaggrin that's vital for skin barrier function. So if it's faulty,
Skin barrier is weaker. Makes
Yeah.
sense.
and then things like stress, hormonal changes can be triggers. And don't forget, asthma and hay fever themselves can actually trigger eczema flares too, not just be risk factors for getting it.
It really is a tangled web. So if we try and synthesize that, the pathophysiology, how do the notes explain the actual biology of what's going on?
Well, it brings together those three core ideas.
Yeah.
You've got this abnormal immune response causing inflammation. You've got the defective skin barrier, partly genetic maybe, letting
Wow.
irritants and allergens penetrate easily. And this leads to the skin being hypersensitive.
Hmm.
These three things just feed off each other, driving that cycle of inflammation, itching, dryness.
Leading to scratching, which damages the barrier more, and round it goes.
Exactly that. Understanding that cycle is pretty fundamental.
Okay. Now, important point. Not every itchy rash is atopic eczema. The notes list differentials. Why is this list useful?
Crucial for getting the diagnosis right. You have to think, what else could this be?
Mhm.
The notes mention contact dermatitis. That's a reaction to something specific the skin touched.
Okay, different cause.
Yeah. Psoriasis usually looks different. Thicker scales, often on the outside of elbows and knees, not the creases. Seborrheic dermatitis, often greasy scales in the scalp, face. Fungal infections.
Like ringworm.
Yep. Lichen simplex chronicus, that's thickened skin just from persistent scratching. And even infestations like scabies can be intensely itchy. So you need to consider those.
That's a good checklist to have in mind. So clinical assessment is key.
Absolutely. History and examination, like the notes say.
Let's talk numbers then. Epidemiology in the UK. How common are we talking?
We said very common. The notes confirm that. All ages, but way higher in children, figures like 10 to 30% of kids.
Wow, up to nearly a third of children.
Yeah, compared to maybe 2 to 10% of adults. So
Yeah.
a big difference.
And when does it usually start?
Mostly before age 5, often in infancy, according to the material. And there are those interesting demographic links too. More common if parents have it, more in urban areas, smaller families, and counterintuitively perhaps, higher socioeconomic groups.
Yeah, that last one always makes you pause, but that's what the data suggests. Okay, so from stats to the clinic, what does it actually look like? Clinical presentation.
The absolute number one symptom, the thing that really defines it, is intense itching, pruritus. If it doesn't itch, you question the diagnosis.
Itch first, then what?
Then you see the visible signs. Redness, maybe some swelling, and dry, scaly skin. In bad flares, the notes mention it can get weepy, oozing, clear fluid, or crusty. Sometimes you see little bumps, papules, or even tiny blisters, vesicles.
Sounds pretty unpleasant. And diagnosis, mostly clinical.
Primarily, yes. Based on the history and what you see on examination, the notes mention specific diagnostic criteria. Essentially, an itchy skin condition plus other features like the typical pattern involving the skin creases, the flexures in older kids and adults, or a personal or family history of other atopic stuff like asthma or hay fever. And the look of the rash itself, acute or chronic changes.
Right. Itch plus pattern plus history.
Mhm.
And the notes remind us again, typical onset 6 months to 5 years, often with that allergy history.
Correct. And because of the itch, people scratch. So you look for secondary changes.
What kind of changes?
Two main ones mentioned. Lichenification, that's where the skin gets thick, tough, almost leathery looking, and the normal skin lines become really prominent.
Like tree bark, you mentioned.
Sort of, yeah. And
Yeah.
excoriation, those are just the scratch marks themselves. Tells you how much has been itching.
And the location changes with age. That seems important from the notes.
Crucial difference. In infants, babies, the notes say it's often face, scalp, and the outer surfaces of limbs extensors. But importantly, the nappy area is usually spared.
Okay. Outsides for babies, not the nappy zone. Good tip. Adults.
More classic flexural pattern for adults. Elbow creases behind the knees, neck, maybe hands and feet, and sometimes just more generalized dryness and itch without distinct patches.
Flexures for adults, extensors for babies, minus nappy.
Got it. Now, something serious the notes flag. Secondary infections. What are the warning signs?
Yeah, infections are common because that skin barrier is broken. Signs of bacterial infection mentioned include golden crusting, weeping, maybe pus spots, pustules, or spreading redness and warmth, cellulitis.
Okay, bacterial signs, but there's an emergency one.
Yes. Eczema herpeticum, caused by the herpes simplex virus spreading in the eczematous skin.
What does that look like?
The notes describe it as rapidly worsening, painful eczema. You see clusters of blisters, often quite uniform in size, which then break down into these little round erosions, often described as looking like punched-out holes. Punched-out erosions, painful, rapidly worsening.
Exactly. Plus, the person might feel unwell, have a fever, feel lethargic. The notes are very clear. This is a dermatological emergency. Needs immediate referral and treatment.
Right. Urgent referral for suspected eczema herpeticum. Got it. And severity is assessed, impacting quality of life.
Yeah, a reminder, it's not just cosmetic. It really affects people.
Okay, investigations. Do we need lots of tests? What do the notes say?
This is a really key point from the notes. Usually, no. Investigations are not routinely needed for typical atopic eczema if the clinical picture is clear.
That's good to know. Saves unnecessary tests. When might they be useful?
Well, rarely a skin biopsy if the diagnosis is really unclear, just to rule out other things. Allergy testing can be useful, but the notes specify it's mainly if you strongly suspect a specific trigger, like a food or environmental allergen, and need confirmation to guide avoidance. It's not for general screening.
So targeted testing for a specific clinical suspicion, not just a fishing expedition. Blood tests, IgE.
The notes say IgE levels can be high in people with atopy, confirming that tendency, but, and this is explicit in the notes, knowing the IgE level doesn't actually change how you manage the eczema itself.
Interesting, but not practice changing usually. What about swabs for infection?
Those are useful. The notes recommend swabs if the eczema looks infected or isn't responding to treatment. Helps identify the bacteria, especially checking for resistant Staph aureus or strep, so you can target antibiotics correctly.
Makes sense. Target the bug. Any warnings about other tests?
Yeah, the notes specifically caution against using high street or internet allergy tests for managing eczema, saying there's a lack of evidence for them. Stick to clinically guided tests.
Okay, good advice. Let's switch to management. We know emollients are key.
Yeah.
What's the overall approach described?
It's presented as a stepped approach. You tailor the treatment intensity to how severe the eczema is right now. But the absolute foundation, step 0 if you like, is emollients.
Moisturizers again, but really emphasizing them.
Massively. They're therapeutic, not just cosmetic. The notes say use them liberally, frequently, all the time, even when the skin looks clear, to repair and maintain that barrier. Prescribe lots. Different types of ointments are often better for very dry skin.
Foundation. Constant emollients. Then for flares, steroids.
Yes, topical corticosteroids. The notes talk about using a steroid ladder matching the potency, mild, moderate, potent, very potent, to the severity, the body site, and the patient's age. Use them for flares to calm inflammation, then step down or stop. Monitor for side effects, of course.
Steroid ladder. Got it. Alternatives to steroids mentioned.
Yep, topical immunomodulators, tacrolimus and pimecrolimus. Good options for sensitive areas like the face or for longer-term proactive use on problem spots to prevent flares. They work differently to steroids.
Okay. What about really bad flares? Systemic treatment.
For severe acute flares, the notes mention a short course of oral steroids might be needed. Antihistamines can help with severe itching, especially at night, or if there are hives too, and obviously antibiotics or antivirals if infection is present.
And diet. Any role.
Only really if there's a proven link after a specialist assessment, especially in kids. The notes say routine dietary changes aren't recommended for most people.
Right. Specialist input needed for diet changes. What about non-prescription management?
Education and support are vital. Helping people understand the condition, how to use treatments, and addressing the psychosocial side. Plus, identifying and avoiding personal triggers, soaps, fabrics, heat, etc. Good general skin hygiene, but avoiding harsh stuff.
Empowering the patient. Good. When to refer? We mentioned eczema herpeticum.
Yes, immediate referral for that. Urgent referral is also needed for severe eczema not responding to potent topical treatment. Other reasons include diagnostic doubt, if it's really poorly controlled, or having a major impact on quality of life, sleep, school, work, mental health.
Severe, uncertain, unresponsive, or major life impact. Refer. Makes sense. And treatments used in secondary care for those complex cases.
The notes list systemic options for more severe disease. Immunosuppressants like sclerosporin, azathioprine, mycophenolate mofetil, also phototherapy, UV light treatment.
Okay, bigger guns for tougher cases and newer targeted therapies.
Yes, there's a list of biologics and JAK inhibitors mentioned for moderate to severe cases meeting certain criteria, often when other treatments haven't worked or aren't suitable. Biologics listed include dupilumab, tralokinumab, these are injectables targeting specific immune pathways,
Right.
and JAK inhibitors, usually pills, block inflammation signals inside cells. Examples given are baricitinib, abrocitinib, upadacitinib. There's also elytretinoin, mentioned specifically for severe chronic hand eczema.
Wow, lots of specific options now for severe disease. And the notes mention tracking response to these.
They do. Often assessed around 16 weeks using standardized scores like ESI, which measures the eczema's extent and severity, and DLQI, the Dermatology Life Quality Index. If the improvement isn't good enough by these measures, the treatment might be changed.
Using objective scores is key. Okay, nearly there. Prognosis, what's the long-term outlook?
Generally, it's a condition that waxes and wanes, relapses and remits. But the good news, especially for kids, is that it often improves significantly with age. The stats quoted are encouraging.
Okay.
Maybe 65% clear by age 7, about 74% by age 16.
That is hopeful for families. Predictors of it sticking around.
The notes suggest early onset, and having asthma alongside it might predict a more persistent course.
Okay. And prevention. Can we stop it developing?
Seems tricky. The notes suggest many strategies tried, like specific diets in pregnancy, breastfeeding duration, reducing allergens early on. Supplements haven't shown consistent strong benefits. Probiotics might slightly reduce incidence, maybe by 20%, but evidence is mixed.
So no magic bullet for prevention yet.
Not really based on this. Emerging ideas focus on maybe strengthening the skin barrier right from birth, or that prenatal factors might be more key than postnatal ones. Still research areas, though.
Work in progress. Okay, finally, complications recap. Infections are big.
Very common. Bacterial ones like impetigo, and the big one we stressed, eczema herpeticum. Fungal infections, too.
And the non-infectious impact.
Huge psychosocial burden. The notes really highlight this. Disturbed sleep is incredibly common. From the itching affects the whole family. Chronic visible skin disease impacts self-esteem, can lead to social isolation, especially for kids, affecting behavior and development.
That constant itch and visibility really takes a toll.
Absolutely. And don't forget the potential long-term link, the atopic march developing asthma or hay fever later on.
Right. Okay, I think we've covered the key ground from these notes pretty thoroughly, from definition to complications.
Yeah, it's a really good overview of the essentials for atopic eczema.
So as we wrap this up, maybe a final thought for you listening, based on all this. Considering atopic eczema involves this complex mix of genes, environment, a faulty barrier, an overactive immune system, and has impacts way beyond the skin affecting sleep, mental well-being, potentially leading to other conditions, what does this really underline about how we need to think about managing chronic inflammatory diseases? Maybe it highlights the need for a truly holistic view.
It definitely makes you think beyond just prescribing a cream. It's about the whole person. We really hope walking through these notes has helped solidify the key information for you.
We do. Keep reviewing, keep exploring. And if you are looking for more resources like the ones we've discussed today, particularly for medical exams, check out PassThemSRA.com and FreemSRA.com.
Thanks for joining us for this deep dive.